Yes, you should be starting to see them now, and I'm trying to share with you.
Thank you.
Give me just a second here.
Excellent. Thank you all. So I hope you all can hear me well, and good morning. And what an interesting moment in history this is for all of us. When I was asked to do this presentation, it just hit me. I was reflecting on all the changes that were emerging in healthcare previously, and then we had this kind of unique moment in history where we've had an opportunity to kind of self-discover. So I really want to thank the DFWHC Foundation for offering me this opportunity to share a few thoughts today and to move through. It's going to be a little rapid. There's a lot of information here, but it's truly things that I think about, and it's things I am concerned about in healthcare. So let's see. I need to advance my slide, and it's not clicking right now. Okay.
Yeah, is it working yet? I can't do. Okay, let's try this again. Now try it.
Okay. There, whoops, there we go. That'll work. I can do that. So there's a few things here that we want to talk about. First, you've heard my background, but a few things I wanted to highlight is that I've had this unique opportunity over my few decades in healthcare to collect not only observation but experiences that have really kind of created where I am today. My primary role, of course, my most important role is husband, father, grandfather, stepfather, and son. But I've had a lot of experience in the federal healthcare sector and in the private sector as well in running businesses and non-for-profit as we kind of go through some of the struggles that we have right now in healthcare. There we go. So I just tell you, we're not in Kansas anymore, guys. Healthcare has changed significantly. And you all are aware of that as you move through kind of what's happening in the space. Let's go back to January of 2020. From industry, we were still, and at the time, the highest employer by industry in the nation. We really had a very, what I call robust respect worldwide in education, training, research, and technology, and I think we've sustained that. We were a world supplier of advanced medical technology. Yes, I know there was a lot of competition internationally for that, but we were still working as an industry. We had massive profit potential, a lot of investment, a lot of private equity movement, and there was a massive amount of untapped potential in earnings, which was creating interesting attention from outside industries. And we were in transition, but maybe not as rapid as some of the others. And according to the WHO, we were best prepared in the world for the next pandemic, which proved to be kind of challenging for us. Now, we did have some problems. And some of these problems were, if you're a patient or you're a payer, we may have to do something different. And it was emerging because it was consuming a greater portion of the GDP. And it appeared to be growing even more and wasn't manageable by any of the what I call policy initiatives or even internal decisions or initiatives by the healthcare industry itself. And by the way, where were the incentives to manage this cost growth? Because there was a lot of profitability, a lot of opportunity embedded in that. The other side of that, though, is we really didn't see significant improvement in overall health. We were challenged in that regard. Walter Cronkite kind of wrapped it up, in the early 90s. The healthcare system is not healthy, caring, nor a system. And sometimes that's a challenge. So I ask you the question, and this is where I start with my classes. So also to tell you, this is not this is my own thoughts. These are not a reflection of UT Dallas or anywhere else I speak or work. Is healthcare right, or is it a business? And we're seeing this debated on the national stage quite often. And when I ask my students, a majority of them raise their hand and go, of course it's a right. Healthcare is a right. And I said, okay. So it's a right. If table 1 chooses to smoke 3 packs a day, they're going to have greater healthcare demand, right, than table 2. Everybody goes, yes. I said, so if table 1 wants to keep smoking, table 2 is going to pay for all their health care, right? If it's a right, that's what occurs. And everybody goes, well, no, that's not what we talked about. That's not what we said. And I said, it's absolutely where we're headed. And then if we're a business, okay, and everybody goes, yeah, but we're a business first. Well, if it's a right, how can it be a business? And I think those are a little bit challenging, and we're always struggling with the balance between the two. I always go to the concept of buyer beware, and there's a massive amount of information asymmetry in the market dynamics of healthcare and healthcare purchasing. That is a significant challenge for us. I compare it to buying an automobile. When I go to buy an automobile, I pretty well know the price. I can research the price. I pretty well know the expectation of the outcome or the value of that vehicle, if it's life expectancy, its mileage, a little bit of its maintenance history. I know those things. And by the way, I certainly have no problem getting into a dealership. And then when I get there, they treat me pretty nice. As I say, sometimes even Mercedes gives you back rubs. But the point is, healthcare is not a pure market. We really don't understand price. Sometimes we don't even know our out-of-pocket price. Then there's pricing that occurs afterwards with surprise billing. I can't guarantee you outcome. I don't understand the quality. I'm not seeing what I call comparative measures of quality to make an informed decision based upon where I spend my market dollars. And by the way, I'm not even the one paying the bill. I have a third party that's paying it on my behalf from money that I've given through employment and or taxation. The experience, I wait to get in, and when I get in, I wait more. So we have a unique dynamic in healthcare that I think we still have work to do with understanding how patients seek care. But let me take you to another one. I think our primary purpose of a healthcare system or industry is health. We say that, we talk about it. As we look at the influences inside our society on our individual health, healthcare is just one piece of this, and I think healthcare is just one way to help achieve health. There's so many more avenues to improving the health of our population across all facets. But yet we focus on healthcare, and we talk, even on the political stage, we focus on healthcare as being almost the exclusive means to health. And when we enter the discussion of rights, it's about rights to healthcare. Well, maybe we need to think about it differently. Because I can tell you, I discovered what health was about at the ugliest place in the world. When I was in Iraq, we were the busiest trauma center in the entire Iraqi theater, 450 medics doing 25 to 26 major traumas a day, 3 craniectomies every day. This was our emergency room. And I can tell you, we had one measure of performance, one single KPI, save lives. That was our measure. I didn't worry about the budget real time. I didn't worry about who was eligible. I didn't worry about access. We all had a unified focus and a unified measure of save lives. Well, I go back to our own system. Maybe we need to take a moment and reflect on our primary purpose. Why is not health our primary measure, our key measure of success? Because we have massive amounts of information. You guys are so aware of that. But yet we never really solidify our system nor our national system where we have enough interest to focus on pure healthcare outcomes. Just health of our population, health of individuals. So when you talk about maybe our population having a right to healthcare, maybe we need to rethink this where everyone has a right to health, and we remap policy in our system to approach that or to create that for them. I just ask you to think about that for a moment. So we have to know to do that, we have to know that the world is changing pretty rapidly around us. The healthcare system, its influences, what's happening in the world. Oh my gosh, the music that I talked to regarding the dance philosophy is always changing. And I don't know that we have what I call a solid enough plan or a choreography to respond to some of that ever-changing music. Healthcare does have a lot of moving parts. And I'll tell you, when you pull back the curtain, it's pretty ugly. But it's offered not only opportunity for disruption and competing industries, but it's also created kind of a mask of solutions. And sometimes I think it takes our eye away from our primary purpose, which is to create health in our nation. So to do that, I want to talk about, well, something simple. Here's the elements and the concepts by which I always evaluate healthcare. I share this in my classes. I talk about this constantly, but I'd like to start with that. But before we do, I think before we look at our healthcare system, we have to recognize there's an elephant in the room. And it's pretty significant right now. And it starts with, sort of that first slide. What the hell just happened to us? Because we have a moment in history where we're a little taken aback and we don't know what to do next. Interestingly enough, in October of 2019, Event 201 happened. And that was a global pandemic exercise in cooperation with the WHO. It was a tabletop exercise of which they evaluated our ability to respond to a pandemic. Interesting that with the timing. They come to some conclusions that we needed to be able to sustain travel and trade to assure economic health. There was a big focus on protecting economic health during the challenges of physical health. That's not well understood by anyone. It was understood during this exercise. It also highlighted the fact that we probably weren't as well prepared across the globe as we should have been, and that we would have a challenge with mis and disinformation in the media, in social media, in perceptions, and that we would probably have to develop rich, deep government-private partnerships globally. Interesting, all of that was on the stage when this happened. This was just taken 2 days ago from the Johns Hopkins site. And you can see the world's best nation, the world's best prepared nation pre-pandemic is now the most challenged. And we've got lots of reasons for this, guys. And I don't want to get into many of those. My point is I want to get into what can we learn from it and how can we move forward. I know Steve Love's going to talk to you a little later this week. I believe it's on Friday. He's going to talk about a COVID-19 data panel, which is a significant element of this and what we can learn from it, particularly from the way we look at COVID implications and COVID impact, because we have variation not only between nations globally, but between states within the US, and then between counties and communities within those states. If you've just looked at the COVID sites around our 4 primary counties here, you can see significantly different ways of evaluating the COVID impact of that county. I think there's an opportunity here in the future. The one thing COVID did reveal about us, though, and this was from Alex Azar, Secretary of Health and Human Services, is that we were an unhealthy nation. We weren't prepared for a virus like COVID. We had a significant unhealthy population with a large precedent of comorbidities. We had a large element of chronic disease that made us very vulnerable to this particular virus. Then you go with, gosh, what other things do we need to fight it? Well, you look about, my gosh, we needed to be a healthy population. We needed to have trust of authority, even sometimes when they challenge that. We needed to have patience, and we needed to have respect, and we need to understand the balance between economic and physical health. We probably weren't ready for all of those things. Even something just as simple as this. This should be simple, guys. I mean, because the mask isn't about you, it's about protecting others around you. But yet we have politicized this to the point that it's potentially harmful to our own population. Well, we learned a few things during this. Number one, the population, we were uniquely unhealthy, and that is in regard to other measures internationally. We didn't really have what I call certainty between the science and tech to solve it, but we had confidence that science and tech would always solve the problem. That's just the way we in America have been taught. There's always a challenge with politics and misrepresentation and seeking the truth. And then we have, and I talk about this in my classes, very deep anthrocultural values that are uniquely American. We thrive on independence, freedom of will, free thought. We don't work culturally in cooperation as a society very well, like other nations sometimes do. We really weren't as integrated and have interoperability in our health systems as we needed, as we had like communities at risk. There was a lot of things in preparedness and supply chain, and I can talk about those forever, particularly about preparedness, but our vulnerability to offshore that still persists today. And then how do we find the data but make that information to knowledge? I'm going to talk about that a little bit more. And then, of course, our staff and the workforce, their own well-being, both physically and emotionally, and then the roles that they play and how those roles have had to adapt. Healthcare itself, the system, may be blind to change. They may not even be willing to, or able to change themselves. Remember, because of the business and the economic forces that are in play. But we also have revealed insurance. You may or may not know the insurance companies had all-time profitability during the peak months of quarantine because the premiums were rolling in and then nobody was seeking care. Then our patients changed what they needed. That has been built up and suppressed and hidden within the quarantine, and they emerged with different expectations. And then we're having some significant ethical dilemmas as we move forward. And we had a lot of heroes, and we praise them and we talk about them. I'm very familiar with this, my frontline medics in the combat zone. But I will tell you that is never sustainable. Counting on the heroism of individuals on the front line is not a strategy. It's not, because it isn't sustainable, and it comes at a significant price when you're trying to move forward. Then we have a few other things that are about to happen. Oh my gosh, we have a vaccine that appears to be imminent. We're in phase 3 trials for a number of vaccines now. We've heard varying days of release. We've heard days of production in the background and distribution mechanisms that have already been established through CVS and Walgreens with the current government. But there is going to be chaos and confusion behind this because of all the things I mentioned about our response to the pandemic itself. Who's first? And why should you be first? That's the paper I'm having all my students write this semester, is I gave them random personas, all the way from US Senator to NBA superstar to homeless person to school teacher to frontline healthcare worker and a few others. And I said, tell me where you should be in the prioritization of vaccination for coronavirus. It's amazing some of the stories I'm already getting. Selfish and selfless perceptions, but that's going to create chaos and confusion in our world. But really, to achieve health, and this is something we tend to miss sometimes because we focus on one or the other based upon where you stand and the way you see this diamond, we have to have physical health and economic health to achieve real health. We have to have that balance. And the pandemic somewhat revealed a challenge that we have with sustaining and integrating both. And then one of my big challenges is that it also revealed our inability to recognize and not take for granted public health in our society. Public health has always been sort of the second-class citizen of our health system, mostly because they reside in government-funded positions within government entities. And of all the times we needed robust, engaged public health, we were challenged. There's an absence of standardization. There's a variance of implementation and ideals and the way they pursue it. And by the way, the things they do great, we take for granted. Clean air, clean water, safe food. Those are things that we just have taken for granted over time. But we really have never focused on a public health response or public health need. And data, information, and knowledge behind that in the public health space is critical. And right now we're trying to catch up. So let me get back to where we were on these other basic elements. So first, did we have a problem pre-pandemic with cost? You bet we did. You bet we did. We had escalating costs that were continuing to increase, not really responding to much policy, and it was not changing. We had percentage growth that was far exceeding our consumer price index or inflation at the tune of 20%, sometimes to 6%, without explanation. Why is that happening? Lots of variations in pricing. And I will tell you, 2020 is going to have a big asterisk by it in the future when we talk about not only expenditures, but also it's a percent of our GDP. Then we have the first escalation of transparency. This is data from the Dallas-Fort Worth community from a year ago on one DRG under the first initiative to help improve that market purchasing capability between payers and consumers and the providers. Well, this is just an example. Pretty significant variance between bill charges between two facilities that are probably 10 miles apart. I don't know which one's right. I just know we need to understand why they're that different. Because I would bet the quality or the outcome expected of each of these can't be explained either. Then we had a great example. This is just from 3 weeks ago. A doctor who went to physicians, he worked for Physicians Premier. He went to another site to get a COVID test. He knew that test was only $8, but yet the other clinic inside the health system he worked for billed his insurance for $10,984. And his insurance company paid it without question. He immediately resigned over the integrity and ethics issues associated with that particular charge. These are things we need to understand as to how it could happen. So to get ahead of the charges now, CMS published these rates this last week. This is the vaccine cost for Medicare. This is what they're going to pay. $16 for the first dose, $28 for the second dose. And this is what they're going to pay. And as I said, they've entered into contracts with CVS and Walgreens as sites or portals with which these can be delivered. Then we get into the other things about transparency and understanding. Only half the patients even understand the EOB or the bills. So as we try to move forward in what I call writing the system, in understanding what was revealed by the pandemic, we have to get back to cost and pricing. We have to understand that, and we need the people who consume care to understand that as well. So some of the younger generations now are more consumer centric, and they actually do drill down and they try to understand it. And they would like to know what their insurance is about. So I think transparency may be a path forward. There has been a final rule on transparency. It does take effect on January 1st, 21. The insurancing, the payer element of this, takes place on January 1st, 2022. This was challenged by the American Hospital Association in courts. It was overturned. And so now they must reveal pricing for the top 300 procedures. It says 500 shoppable items, but top 300 bundle or likely procedures, and 70 are directed by CMS. This transparency is going to be a little interesting because there's been a large pushback that it does nothing to help patients understand their out-of-pocket cost. Well, that's the assumption here that out-of-pocket is the only thing of interest. I would challenge that to say, I'm interested in total cost because maybe my premiums could be reduced in time. If my total costs go down, then maybe I can change my copay or my co-insurance strategy. And maybe I can reduce my out-of-pocket exposure as well as my premiums. So transparency of total price, and by the way, stop the surprise billing, could be a significant element of the way in the future. Here's another part that's a little bit we need to be aware of, is that as you hear more about public options, which could significantly affect reimbursement in the future, for the first time in history, membership of the American Medical Association actually support a single payer. And that is part of a new generation of physicians entering into the workspace. Then we have a few issues regarding quality. Well, we sometimes the patients don't understand. They make assumptions that if you're licensed or if you're credentialed, quality is always equal. But you can see through this, sometimes they don't trust the outcome entirely, and they just want to cover their losses a bit, so to speak. Well, we've spent a lot of money. You were number one in healthcare by almost double in economically developed nations, but we're 28th in life expectancy. We're 31st in infant mortality, 16th in heart attack mortality. And by the way, we could add, we were vulnerable to the pandemic. And for the first time in history, our life expectancy declined. So it's hard for us to say we focus on health when we spend as much as we do in health care, but yet our measures of health compared to other nations is still rather challenging. You can see this chart, life expectancy versus health expenditure over time. And this is in years. And you can see this is from 1970 to 2014. Look at all the other nations. You can see Japan, almost 84 years, and they spend $4,000 per person on the average. These are normalized dollars. But look at the US. We're lower and significantly more in expenses. And this is just through 2014. That's gone up to 11,500 since then. So you can see we have a challenge of where we stand in quality throughout the world. But yet we as a nation assume ours is the best. But I could tell you this particular chart on COVID proof, we really weren't quite ready. I mean, you can't stop our virus, but we were challenged within the healthcare system as well. And we were challenged with the pre-existing conditions of our population. When I talk about preparation, I mean generational preparation. I mean decades of preparation to have a population that's resilient enough to withstand the challenges. Then we talk high reliability, safety, and safety elements within our system. Are we doing that as well while we're trying to respond to the pandemic? We have pretty good safety measures. We do pretty well compared to most, but yet we still have challenges. The best industry in the world for high reliability is the airline industry, because a loss of an aircraft is a significant problem for transportation and customer trust inside the safety of the system. If the healthcare industry ran the airline industry, we would have three 737s crash every day. We have avoidable losses of life to the tune of 630 something per day. But none of it's visible because the transparency just isn't there yet. And we have to move to focus on health and protection and safety of others. Access is a major issue. This is what I call my psychedelic donut. And this is what's still yet to be insured. And that's in the white that says uninsured. Over here, the 17.6, that was what was covered by the individual markets through the Affordable Care Act. There is some interest in expanding that with the public option, depending on which way the election goes and how the efforts are going to be to move that forward and who's going to have enough political clout to make it happen. But we do have an interest in this because they believe that the uninsured is denied health through their limited access to health care. We have to look at that differently because we need to pursue health and not just equate access to healthcare is the entire solution. Then we've had changes in access and expectations, massive amount of movement toward telehealth solutions and telehealth interest. And I just think that, now we got some patients that are afraid to go into healthcare. 53% are afraid to go into the healthcare setting because they're afraid of getting it. I've dealt with that with my mom, who's had a few health conditions during this time, and she's of vulnerable age. And just getting into the clinic has been very problematic for her. Then you have significant increase in the telehealth visits, and then you've seen a decline in the office visits. Now you're seeing them shift back again. Well, why is that happening? Well, the government, Medicare, Medicaid, continued to cover telehealth and has made that a permanent change. Insurances are trying to cover less and less telehealth visits. I don't understand exactly why, but I can tell you the expectation of patients may be, I want more telehealth. I want to have responsibility for my own health choices. I really want to be a participant in my health. Then you have others. Walmart has stepped into the industry significantly, and you've seen they've opened, this one's in Dallas, Georgia, their first clinic, 10,000 square foot clinic, and where they published all of their prices, and that's the total price. We take Visa, MasterCard, Medicare, Medicaid, and your private insurance, and we'll take cash as well. This has started. They've now announced, I believe, 2 more openings in that local area. Pretty significant changes. And by the way, 90% of the US population live within 10 miles of a Walmart. They could make a movement in the primary care portal for our healthcare system. Then a subsidiary there, Sam's Club, has opened an online system, an enrollment system where you pay a membership and called 98.6, and your telehealth visits are $1. Interesting. I think there will be a challenge on this with quality, but they're opening the portal for access quite easily. Then you have just experience. What are we seeing and what are we experiencing? What do we expect? Well, I think we have to look through their eyes. We have a pretty rapid change in healthcare consumerism, but I think that's based upon the way we consume all products and services. And I can tell you, during the pandemic, we've learned to shop differently. We've learned to buy differently. We consume information differently now. We're online, we're engaged, we teach online, we talk online, we share thoughts online. We buy online, it's delivered to my doorstep without risk. Well, maybe we need to be thinking a little about that as we adapt our healthcare system to the way that consumers are looking at healthcare. There's a lot of opportunity here if we're willing to see it. And then like sites like joepatient.com, whoops, sorry. I lost control all of a sudden. There we go. joepatient.com is well, okay guys, let my slides catch up, because joepatient.com is actually establishing a membership site that allows you to look at and compare healthcare systems and healthcare pricing as well as outcomes, and improves you as a shopper. There we go. So it allows you to be a better consumer of healthcare. It allows you to be knowledgeable. It allows you to be proactive and to ask questions about your own health system. Then we have, there we go. Then we have this ever-changing expectation of customers called the silver tsunami, as I call it. And the book by Dr. Atul Gawande, Being Mortal, really highlights the expectations of an aging population. But it really says we as a nation aren't prepared for this either. And I think now them being a very vulnerable part of this population related to the pandemic and its exposure, and how we're having to deal with the ethics and the vulnerability of that population. We failed in some of the early nursing home responses. And I think we have some opportunity to do better with this population. Then you have the narrative that you're hearing about, Medicare for all and other social systems. It says social systems, more public option systems. Just be aware of what it really means and where that's going. When I talk to my students about this, I keep reminding them that no matter what federal program is offered, you always pay for it. And that's the kind of expectation we need to look for. This is really highlighted well in Dr. Gawande's article, Is Healthcare a Right?, where he talks about the way we look at Medicare as a population as an earned entitlement, something we've contributed to, rather than a free plan that's offered to everyone in the nation. Then we need to look at, understanding as well about how do we look at our institutions. We're well aware of U.S. News and World Report and its racking and stacking of medical centers across the nation. But there was another institute, the Lown Institute, that it's partnered with Washington Monthly, that has created a new ranking system that's based upon contribution to the public good in 3 categories: patient outcomes, civic leadership, and then value of care, overprescribing, for instance, and then pay inequities between leadership and the workforce. It's pretty significant. Out of 3,500 hospitals, JPS in Fort Worth is number 1. Number 9 is Parkland. Pretty significant. And so I think that I'm excited to hear this later this week that Dr. Henderson from JPS is going to talk about innovation in healthcare and what that would mean. I'm eager to hear that because they have had a lot of coverage and a lot of it public exposure and opportunity as well with this particular element. But I can tell you, we've had a lot of hospitals close. I just read an article this weekend regarding the south side of Chicago, and it appears yet another hospital may close there because of the inability to sustain financial operations. And they're creating essentially a healthcare desert on the south side of Chicago. And then when everybody goes, well, it's single payer. Well, you know what, guys? I think we may already have arrived. I think we've already opened the box on that because the CARES Act really required us to cover everything COVID related. Well, how far reach is that to move to another chronic disease or another condition or another virus? It's not too far. So I think maybe expectations have already been set. And if anybody thinks the government solution is the right answer, I've worked in the federal government way too many years, almost 3 decades. And this is a typical structure of the way healthcare is delivered in the healthcare in the federal health system. Very complicated, very interrelated, and it's very slow to respond. It's not very nimble. So I'm not so sure that a federal solution is necessarily the right answer. And then we have our others, is how did we get where we were with our current CDC? There was a lot of issues with the current administration regarding the CDC. The CDC prior to that had a lot of issues. Even in the early phases when they had authority for testing, there was a lot of opportunity here for us to learn how to do this better. And I think we need to learn to trust an organization like the CDC again regarding national health response. We need to do that better. And then just reporting. We had a lot of healthcare reporting. I mean, I had a lot of aggregation, but was it really systematized to improve and to respond to health needs, or was it really a business asset that was focused in aggregation? And could that network of hospitals in reporting become a national asset? Yes or no? So, and a great example was we had a health system in Texas who had built a dashboard and was reporting COVID entirely, and they were a little ahead of the curve with Texas. And so they started reporting actual cases, but they were not exactly aligned with the way Texas wanted them reported. So Texas went out and kind of publicly shamed them for doing it. We can't do that. We can't do that. We have to be able to understand not only what's being reported, but why it's being reported in that way and standardize that across the system. So I want to take you through a few thoughts now about how you as a leader inside healthcare, inside the world in pursuit of health, can maybe shift your mind a little bit, maybe have some what I call mind shifts to rethink about what we do and how we do it in healthcare. And that's where the word dance come about, because I have a few letters, a few thoughts associated with each of the letters that I want to walk you through as I go into the kind of the final phase of today. First of all, data. We have massive amounts of data in healthcare. Pretty significant. Maybe we have too much. The problem is they sit on so many different platforms and they're not easily accessed. And yet they're also of great value. There's interest from what I call emerging disruptors to own that data or to use that data. But who really owns healthcare data? Some advocates say the patient does. Healthcare systems say we do. The platform it sits on says we do. I think there's going to be a huge discussion in the future about who really has the authority to use data and how it is to be utilized. But I consider healthcare data sort of the new oil of our industry, because there's a lot of untapped wells out there right now. Now it gets a little confusing because some people look at it, as data, and then you get information, and then it goes into knowledge and insight and then wisdom, and then you get into conspiracy theory pretty quick. I find this amusing, but it's not surprising to me. But data must become information to be of value. And I don't know that we necessarily do that in a standardized way. I know when I was in a leadership role, I always created an information shop. I called it my data cell. And I always had a team of independent experts that did nothing but translate data to information to dashboards. And they measured things that were important to us as an organization, not only our ultimate outcome, but also our journey to achieve that outcome. And we captured everything, but we didn't present everything. Another real important element of that is in that information journey was to teach people how to use it. When I chaired our executive staff, and I did have an a business committee that dealt with just information that we collected from our med center. And we were 6,000 people, and we were probably 500 beds, and we had 500 medical residents, and we were taking care of 1 million patients. I had this dedicated committee just to understand how we measured things. And when I had the physicians and the nurses and some of my other administrative leaders in the room, I knew very well they didn't understand. I know they didn't understand exactly what and why we were doing things. So before the committee would meet, I would meet with the presenter and I would go through all the slides and I would ask questions. I knew the answers, but I would ask questions to teach and educate the members of the room. So every one of my committee meetings was like grad school. It was like a course, because you would enter the meeting not only not to report or defend information, you entered the meeting to learn. And we never had accusatory meetings. Nothing was ever discussed there that was threatening or uncomfortable. I wanted people willing to go to the meeting to learn, and I wanted them excited about sitting in the room. I didn't want them feeling that, and you've been there, I didn't want that sick feeling in your stomach, having to sit in a room and pray they never saw your data, or they never asked you a question about something inside your scope of authority. It's real important we understand when we go on this information journey that we create places like that to safely learn. We have to take data, turn it into information, which becomes knowledge, which becomes wisdom, which then develops our strategy. And I love that, because this is what I teach in the grad school strategy at UT Dallas as well, both to physicians and to administrative professionals. And I can tell you, this is the foundation of strategy. is great wisdom derived from understanding knowledge, the data and information. Then from there, you can move on the execution phase, okay, and measure your progress with great information. You can look at your performance. Okay, are we balanced? Are we doing and achieving what we promised? And is our execution consuming the right level of resources? And do we have the right intensity from the organization to support that? And then are we making adjustments? And we're doing the adjustments in a nurturing way. We're not harming people. We're doing it in a nurturing way to learn. And then are we rewarding? Are we celebrating achievement? I can't tell you how important this sequence is in the trust and integration of an organization. And by the way, how about we do this across communities? How about we do this as actually competing health systems sometimes, if we have a common interest of health in our own community? But we have to really be realistic, and we can't say we were ready or are ready regarding what I call systemness in our communities. And I talked about that. Did we understand where the supply sources were across the Dallas-Fort Worth community when the pandemic first broke out? Did we have very nimble ways of determining ICU bed availability, ventilator capability, meds, research, common meds capability, outbreaks, hotspots? Yes, but did we really have a systemness about this, about how we responded to the pandemic? And by the way, had we exercised it prior to that, and had we had adequate preparedness? See, I think we were quite vulnerable in that regard. And not just us in the Dallas-Fort Worth community, it's throughout the whole nation. We just had never seen value in that systemness or connectivity between competing health entities, because the business prevented us from doing it in what I call in an open, trusting way. We found ourselves with weak supply chains. We found ourselves without bench stock or storage capability, and we're still struggling at times with how we get adequate supplies of PPE and drugs and proven therapeutics, even staff. Could we share, and were we willing to share staff? So those are some things I would suggest that we begin to think about as lessons under this. Again, what the hell just happened, guys? We need to learn from this. Thank goodness we had reliable internet. And if any of you are involved in that, I want to thank you. Because could you imagine what quarantine would have been like without bandwidth? And the bottom line is, we need to be healthier next time we have a pandemic or a concern with this. You also have to assume, you can't assume nothing's going to change. It is going to change. I've already seen some narrative that, well, I can't wait to get back. And this is from CEOs. I can't wait to get back so we can restore the lost revenue. My board's all over me about restoring the revenue. Wow, we really need to think about what we do, what we serve, and how we serve, and what our purpose is. We need to restore health, and we need to find a path to do that, and we need to be part of a community. That community contribution is real important because of where we live and how we interact with each other. And you got to see, things did change quick. I don't know how many of these will go back. As I said, back when I was doing benefit design, I helped create TRICARE, and I wrote the Medicare supplement called TRICARE for Life. I wrote that law and passed it through the Senate and House when I was active duty. And I can tell you, I've never known a benefit we took back. So when you kind of open the door for a little bit of opportunity and you relax some things, expect them to probably be retained. So for instance, telehealth across state lines, I think you're going to see a massive challenge on licensure. I was reading just the other day that there's only 14 physicians in the nation who are licensed in all 50 states, who can practice in all 50 states. We have a real challenge with those barriers and those limitations between offering health systems across state lines. We also need to look at how care is going to be defined. Who is the care team now? The advancements in advanced practice practitioners and providers. the roles of maybe nurse practitioners and PAs in our future. And then, did we have a production capacity that responded with ventilators and PPE? No. But we have to have the courage to change those things. And we have to understand we were vulnerable. It goes all the way back to the hurricane that hit Puerto Rico many years ago. We were vulnerable then to saline. We were without saline for a period of time. Who knew they were mostly manufactured there? And if you look at even PPE manufacturing, the early part of this year, we had one particular supplier who had to recall 7 million sets of PPE because the assembly site had been contaminated and they didn't know. We have to really have what I call chain of custody across the entire process of healthcare. That includes drugs, that includes equipment, that includes our PPE. And by the way, that includes the way we select our staff and train our staff. That chain of custody is pretty important. The very first thing when I arrived in Iraq was I assigned a team to track chain of custody for every drug, every hypodermic needle, and every tissue and/or amputation extremity we amputated. I wanted to know that they were disposed of in a safe, respectful way. Had to change some processes because I wanted an entire chain of custody for our need. We also have to understand that everything is globalized and that everything now in the local is now exposed globally and influenced by global perceptions and global information. We really have to be focused on learning what's next in this process. Well, we have a lot of people who are interested in healthcare. I put this slide together in May of 2018 when I first started teaching at UT Southwestern about, there's some interesting companies beginning to talk to each other and move into the healthcare space. Well, this is what it looks like now, guys. It's pretty significant. Lots of changes in healthcare, lots of entering entities. You can see Apple looking to get into the records business available in their cloud. You can see Google interested in data, artificial intelligence, Best Buy in the senior care market. You can see Walmart and what they're doing and their partnerships that are ever changing. The government recently partnering with Walgreens and CVS Health to distribute vaccines. You can see vertical and horizontal integration. For goodness sake, you can even see 23andMe when you send in the specimen to look at your family origin. They kept all the data on your DNA in predisposition to disease. That's why GlaxoSmithKline bought ownership in 23andMe. So you can see a lot of entities prior to the pandemic were knocking at the door. And they were knocking at the door because there was $1 trillion of waste, according to Berwick. $1 trillion of waste that is available opportunity, business opportunity in the healthcare system because it didn't have the ability to adapt itself. They were hoping for massive disruption. And they started. This will continue because a lot of these companies are not in healthcare, but a lot of them are among the most trusted in the world. And everybody goes, oh my gosh, my record's on Apple? Yeah, sure. Well, I'm not going to have my privacy risk with that. Are you kidding me? Look what you posed. When I talk to my younger folks, I said, I'm sorry, but privacy is different for you than it is for my generation or my mom's generation. Then we have, who knows? And I put this out there only to say, don't assume nothing's going to change, because it will. We have a dynamic House, a dynamic Senate, the presidency undetermined, the Supreme Court, newly seated Supreme Court, and then of course the residual effects of the pandemic. It's all out there, guys, and it still will influence healthcare. It's just we need to try to keep our focus simple. It should be health. We also have people that are challenged. We have our patients that are challenged. I spoke a couple of months ago to the Oncology Center at UT Southwestern on a presentation about you really need to see things through their eyes. They're afraid and they're very vulnerable right now. We also have a lot of people that had pre-existing conditions that have been quarantined. There's an estimate that there's $68 billion worth of mental health care need right now. in our nation, and we don't have the capacity to respond to that. So we have to understand the challenges of those we serve, and that includes our own staff. I also need to share with you that, you need to share openly what your vision is from whatever level of the organization you are. Don't always think everyone that's in the organization knows your vision, because they don't. You have to constantly remind them of the big picture, where we're headed, who we serve, why we serve. This is how we protect our culture. This is the way we create trust. This is the way we work with each other. This is the rhythm of our organization. But the leaders need to establish vision at all levels. And if you're mid-level in an organization, you need to map yourself to the bigger vision. Here's our role in that big picture. Here's what we do to move to the next stage. When I arrived in Iraq, I had a challenge because I was the only non-physician to ever command there. And I felt a lot of pressure from that. All my predecessors had been surgeons, and I was the first non-physician to command because I had most experience and was most qualified at the time. Well, I approached it differently because I had seen pretty significant emotional challenges with the folks returning. This was a pretty significant place. So I had what I call my commander's call, where this is sort of like a town hall, but everybody had to show up. And this was about 2 months before we left, and I had everyone, and I went through, explained the environment, shared pictures, and then I shared pictures of the trauma, of some of the more what I call extreme cases of trauma. I had about 6 people get up and leave and go throw up outside, but I wanted to sort of prophylactically prepare their brain for the visuals, because our expectation was once we land, we may have to start work within an hour. It's a pretty dynamic place. I also challenged them I said, I want you to return better than you left. I want you to return emotionally healthy. So I challenged them to improve themselves across one or all parameters. Number one on the left being spiritual. Improve your spiritual health while we're there. The next, improve your emotional health while we're there. The next is improve yourself financially. And the last is physically. And I told them mine was physical and spiritual. I told them that's my goal. And over time, while we're there for the number of months that we're deployed, I'm going to ask you where you are on your journey, because I want you to return home better than you arrived here. It was incredibly successful. And actually, I spoke at a national mental health conference about this particular philosophy to prepare and prevent PTSD in the world of medics. But it takes this kind of personal connection and leadership to make that happen. Because I would share with them my own stories. I wasn't a young guy. I was 50 years old when I was there, but I had to go. I had to be there. I had sent too many before. It was a point of integrity for me. Then you have to, just don't assume. This is myself and little Hallie B. I attended a child's fundraiser in Fort Worth a couple of years ago. And this young lady walked in early in the room, and she walked up to me when she saw my uniform, and she said, wow, you must have some stories. And I said, well, yeah, but glad to meet you. And then I asked her mom for permission to take a picture with her. And we chatted for a moment, and then we went about. Well, little did I know that when this big dinner with hundreds of people attending, they introduced the keynote speaker, and it was little Hallie B there. And Hallie B suffered from a rare bone disorder where she needed a bone marrow transplant to survive. She created a foundation called Hallie's Heroes. And Hallie's Heroes was on a journey to find matches for people with the same disease. Incredible. Hallie always said, I'm looking for my hero. I'm just looking for my hero. Well, she found her hero 2 years ago, after she had already saved the lives of about 100 other children through her nonprofit. And she went through a bone marrow transplant at Cook's in Fort Worth. She did very well for that. She was cleared from that, went home, and they discovered bone cancer in her left leg. Hallie put on her hero mask again, and she went through the journey of a leg amputation at MD Anderson in Houston. And she is now surviving quite well with a great attitude. And she is a poster child for the way you respond to a challenge. And when they asked, said, "Don't you feel bad about it?" And she goes, "No, God put this on me because he knew I was strong enough to be an example for others." I never knew that whole story from just that little moment with Hallie, but she's been a hero of mine and somebody I follow right now through Facebook and her journey, because I've never known such courage in a child. And then this is the other thing. Okay, yeah, this one goes up, pops up color. That's me standing there. Being an architect, and you probably saw my bio, as I started healthcare as an architect, and you just happen to do that. You have to be able to sketch a little bit. So while there, these are the mortar walls that protected us from rockets and mortars. We were rocketed about 3 times a day the entire time I was there. And toward the last of the month, I decided to paint a mural on the walls that entered the hospital, and give ourselves a little identity, because I wanted people to smile as they walked by here. What I learned while I would paint, and I had 1 hour in the afternoons that I could go paint. It took me a month to do this. They would talk to me for the first time. I wasn't Colonel Taylor the boss. I was this guy in a floppy hat with paintbrushes. And they would tell me their stories. They would tell me their fears. They would tell me where they were on their journey of personal improvement. They would share stories with me while I was painting. My regret was that I didn't do it earlier, because they got to know me, and they got to know the things I was afraid of, and they got to know what I was about. This was an important moment for me to understand. By the way, it's gone now. When we left Iraq, we painted over all the barrier art, so it's no longer exists, but it served its purpose for that time. Then you have to get into asking questions. You need to make sure we're ready to do many things. And let's start with another A, artificial intelligence. Oh my gosh, this got real, guys, and it's moving rather quickly. But I think we need to be very careful and be responsible about the power of AI and how quick it's moving and its applications. Because remember, healthcare is about humanity and humanness. And I think we need to be aware of where AI can really help. It's certainly helping right now in vaccine development. But you can see folks like Google Quantum really pushing forward with their model of super processing. And I think it's going to be of great value, but we need to be responsible about AI. The others are, in the physician space. And I've talked to a number of docs, and I've talked to a few medical schools, and I will tell you, the physician of the future is going to be partnered probably. I call them Dr. Bots sometimes. But what if we reimagined an engagement in an exam room where there is an AI robot that listens to everything and already knows all of your test results, and by the way, is acquiring knowledge real time while the doc is talking to you and working with you, and the bot is capturing and putting everything in the electronic record, and by the way, listening and assisting in the diagnostics. That would be quite a pivot, because the doc then would be focused on you and would be focused on empathy. I think there is probably an alternate future in AI that could be pretty powerful in the engagement side of care, but it may redefine the way we train physicians. There's lots of potential in this. It's already started with augmentation, with Sensory. There's lots of things now to enhance hearing, to enhance smell, to enhance visual as well, and vision. Lots of things. And then how do we take AI maybe and create equality? And then how would we take AI and leverage it in a response to the public health needs we have? Maybe that's something, that we use to help us integrate in more of that systemness right now that we need to have in a pandemic lessons learned scenario. The challenge is that when you look at worldwide, only half the world is online. And it could further divide. There's a risk of AI further dividing our society between that, this is their term, the gods and the useless. And then if you're online, you're in. If you're not, you're out. There's a real challenge for that. We have to be careful about the power of AI. Then we get into asking questions, and you got to listen with your eyes. I'm a real fan of what I call enhanced listening. And you need to see and understand differently. I had a young lady at one of my hospitals when I was in the Air Force, and she had gotten into some trouble, and it started with the loss of her purse. When we drilled further down, it found out that she had lost the purse when she passed out drunk in some stranger's place, and she reported the loss of the purse, and she was underage drinking and all kinds of other things, which is a little bit of a problem in the military, particularly as a young entering airman. And you have to understand, as her commander, which I was at the time, I felt like a parent. I felt like I was responsible for them in the absence of their real parents. So I had to administer some very deliberate paperwork punishment, but I asked her boss to bring her back the next day in a casual setting and talk, because I needed to reestablish a different relationship with her. So the next day she did, and it was casual. And I asked her if she understood the risk and her choices. And I said, so she goes, so what now? And I said, well, I just need you to do one thing for me. And she goes, what's that? And I go, promise me you'll just never do it again. And her response was, are you kidding me? I go, no, and I can wait. It took her 12 minutes to promise me she wouldn't do it again. So when I talk about listening with your eyes, for the next 2 years, when I would go through her workplace, she would see me across the room. She'd run up to me, stop, salute, and go, I'm still good, sir. I'm still good. And the last day when I relinquished command and walked away, she was the last person I met as I was leaving. And she told me once again, she goes, I'm still good. That's the power of listening and understanding and creating trust. I never forgot the story, and I know she's doing well today. You also have to listen and observe in different ways too. This is Dr. Bailey, the trauma czar, when I was in Iraq. When we were going to a mass cal event, he was the boss. He was the boss. My job there was to, even though in a normal day I was his commander, but when we went into mass cal, he ran everything. I would go get Gatorade and I would mop bloody floors in the emergency room is what I would do when we went into mass cal. And I would just keep everybody away from distracting us. But you have to watch and see who's doing what. Who's doing what? How they're responding. Are people engaging or are they fearful? I had young kids here who, by the way, at home, were trained to file papers back when we had paper records. And over here, they were tagging bodies and offloading the choppers with casualties. Oh, and by the way, they also, from the chopper to the emergency room was about 100 yards that they had to roll a gurney. And we took care of insurgents. We took care of bad guys. And during that 100-yard journey, they had to search that particular patient for bombs and grenades. And they had to detonate it outside the ER. And every one of them said, boss, I got it. I know what I'm supposed to do. So when I think about that in regard to our focus of purpose and our need for healthcare, you got to listen with your eyes, because I had to watch them and see when they were becoming shallow or disengaged. And usually it took a while to understand it, but when they couldn't make eye contact with me was my first sign. When they couldn't look in the eye was the first sign we had a challenge. And I would usually engage that with someone else so that they would never have to face me. The other part is we have to adapt to a new workplace. I mean, right now we're adapting to a new conference scenario. I'm finding it, the commute's pretty good. I'm enjoying that, but it's not the same as being face to face. It's not the same as helping you engage emotionally about this beautiful industry we're in to create health. And that's what I feel I'm supposed to do, is to energize passion in everybody that serves in this space. And for those who aren't passionate about it, Maybe help them find an off-ramp, go do something they care about. Because if you don't care about people, you may not be in the right place. And I think adapting to the new workplace, we need to find a way to preserve that, not only for our patients, but also for the staff that serve them. We have to find a way to adapt to this new work scenario. In the future, it will never be as it was. Then we always have a challenge with equity and equality. They're not the same, and we have to understand the difference between the two. But we have to normalize a process so that we have standards and we understand what variances look like inside that system. We have to standardize this to create trust, because part of this is, is creating a predictable model of outcomes. Too much variation creates psychological insecurity, and people begin to react and become a little guarded. We need to have a culture now. We need to create a culture where people are aligned and they understand and can predict what will happen. You as a leader need to be predictable to create trust of your subordinates. So normalizing that creates this sort of standardization so that we can reach across all the areas that serve health and create that culture of safety and trust. So you can be vulnerable openly. You can express wacky ideas and not be ridiculed. You've got to create a standard that's focused on caring for each other, that's focused on the health and caring of others. Then we get back to, our public health challenge we had. And we talked about this before, is that we really didn't have a health position as a nation to respond to this particular virus. We need to do better than that. We need to normalize to create essentially trust and equity and understanding. Part of me right now in this, and I wished I were in a room. If I were doing this in a lecture room with you guys, I would have a massive whiteboard and I'd be sketching the entire time. I'm very visual. I love pictures and I love dots. I love this picture because it's time for me to be in a room locked up for a week with some great minds and start redesigning the way healthcare looks, standardizing it, aligning it, creating a different system for the way things connect. But the foundation of that is data, information, and knowledge. That's the foundation of that, because otherwise we don't know where we're going. Part of this is that we have to make sure we're focused on the right thing. I show this as an arbor or trellis, and sometimes we miss the purpose. The purpose of an arbor or trellis is to support the healthy growth of a plant. But sometimes we become so focused on the trellis, we lose sight of its purpose. That's really kind of unique to us. So I want to challenge you with another metaphor regarding a camera. You can see that going into focus there. Dr. Don Norman, he is a designer professor in California at UC San Diego. He has some great videos and great narrative about designing for people, designing for humanity. And he uses a metaphor of a camera, and it really resonated with me that we're so focused on the camera. We build a camera, we look at all the f-stops and aperture adjustments and timing and sequencing and all the light settings. I mean, huge things, the way it processes, the captures, everything. We're so focused on the technology of the camera. Sometimes we lose sight that its only purpose is to capture an image. Just to capture an image. I think about that in healthcare. We're so focused on the healthcare system that maybe sometimes we've lost sight our purpose is to create health. Health is our image. The camera has become our healthcare system. And so maybe we need to just remind ourselves sometimes that healthcare is just a camera in the pursuit of health. And there are other ways to capture an image, such as art. And I go back to my barrier art and my painting. I go back to sketching. I go back to so many other ways to capture an image. But we're focused on the camera design. And I think we need to open our minds a bit up and find a way to integrate all of those elements. Another one is connection and communication and a few other C's. First of all, we need to learn to communicate differently. We have had this traditional way of communicating not only amongst ourselves, but within our patients. And there's massive barriers in that. And I'm not talking just language. I'm talking what we speak. We need to communicate openly. We need to communicate with our communities. We need to leverage these venues, these massive venues of social media and new communication methods to share great thoughts about the pursuit of health and why health is important. But we need to understand the kind of what I call the variance of learning and the variance of receiving of those we need to talk to. So communication is really simple, but it's so important. We also need to have people understand why we exist and what our role is as an organization. I know if you've never written a why statement, I would ask you, write your why statement. My why statement is my job right now, at this point in my career, in my life, my job is to help others discover their passion, to help others discover their passion, to serve in a different way, and to take that passion and serve a higher calling. That's what I say my why is right at this moment in my life. But that why is a guiding force. It's sort of the North Star for an organization as you have it. And it's incredibly important. Let me go back and I will tell you, I spoke last year at a healthcare financing conference, HFMA conference in Austin. And I challenged the accounts there. I said, I think you need once a week to get up in the spreadsheet. You need to go to the waiting room and you need to talk to a patient and talk to their family. You just need to understand why they're there and what they're struggling with. You need to know who we serve and why we serve them. Because it's important to connect what you do every day at that desk with the vision and the purpose of your organization and how to better serve those that count on you with their lives. I said, if you're not moved by that, truly, if you're not emotionally moved by that or touched by that, you probably need to go back to your desk and write a letter of resignation and go do something you care about. Healthcare is just too important to not do that. Connection is another one. We talked about it as well. Connection to where, oh my gosh, in this particular time in the pandemic, caregivers have become caretakers, have in a new environment of what I call exponential caring. Sometimes careless in our current structures and have to be very careful. But this bedside attendant for those at the end of life is becoming almost paralyzing to individuals as they've had to become the next of kin, so to speak, in the last moments. This connection has been lost. We've lost the connection with family, and the caregivers have had to fill that role in some of these particularly in the early phases of the pandemic. That has had long-term effects on people, and it will continue to have long-term effects on people. Then we talked about this earlier with changes in access, changes in expectations. People are going to want to buy online. Amazon's teaching us every day how to do this quite quickly and the way we can shop and compare. I think that's probably not going to go away. I would love to be able to get online, find the next available appointment, talk to a doc right now, look at the price, look at how they're rated on quality and bedside manner, make a selection and pick it. And I don't really care if it's in my health system or not. If I'm paying out of pocket, I really don't care. So we really need to understand the transformation that's going to occur. We also have to figure out, don't let the technology separate us too much. Telehealth is going to be here to stay, guys. I expect it to go further and further, particularly in mental health. I'm working with a company now about connecting a psychiatrist in the communities right now about how we capture that data and enhance the value to the patient in that relationship in connecting them with need. And then, you know, I told you I'm a son, so I still have a challenge at times. I have a mom who's in her early 80s that lives here locally, and she lives alone. That's my mom and my dad, and my dad on their wedding day in 1954 in West Texas. My dad passed a few years ago, and they were married over 60 years. And my mom lives alone and chooses to, but she's struggling right now. She hasn't touched another human probably in 8 months. We meet on the patio and talk, but I do not want to risk causing her harm. To make it even further, she's the caregiver for her older sister who's 90 in a nursing home. This is them meeting 2 weeks ago for the first time since March on a plexiglass panel. And it was a big moment for my mom and for her sister. But connection right now is important, and people are losing that. We need to find a way to continue connection as we navigate out of this particular challenge that we have in this system. Then we need to look at things differently. I go back to the E's now, is we have to embrace technology, guys. And you are at the leading edge of that, but we have to help, you all have to help others embrace technology responsibly. Technology will not be the answer to everything, but it will enhance solutions and our path to health. And technology is here to stay. It'll help us understand, it'll help us trust, it'll help us really navigate what I call a solution to the future path of healthcare. But you know what? You know, health's going to need more than technology sometimes. I thought this picture was amusing as you talk about healthy behaviors and go technology, but you can't always change some behaviors. We have a long ways to go to encourage people to make better choices in their lives. And then we have things kind of pivoting. This was a great site I read about this week about empowerment of nurses. This is going to happen. And this was born out of some of the, what I call depersonalization of healthcare to staff members during the pandemic. So this company created a site where nurses put themselves in the pool and they are interviewed by employers. The nurses interview the employers, and you select where you want to work based upon culture and conditions and compensation and respect and value and everything else that you think is important to you. It empowers now, it just pivoted, completely reversed the scenario. So it empowered the staff to select where they want to go. This company within 3 months was fully capitalized, tens of millions of dollars and invested, and they've already have tens of thousands of nurses already registered and listed. This could happen. A lot of transformation occurring in the health system. The other part was we have to be aware of the way they see healthcare. This is our patients. This is their point of view. Kind of scary, but this is the way a lot of our patients see healthcare. We have to understand what it's like through their eyes. We have to understand the frustration of a parking lot with those when you're not feeling well. We have to understand the frustration of signage and not being able to find your way to places. We have to understand what it feels like when you're not feeling well to go into a dirty bathroom. We have to understand through their eyes what this looks like and how we could do it much better. We sometimes have become so accustomed to this that I don't think we can see it. I know when I designed buildings as an early architect, everything was from the customer's perspective. And I had the ability to visually walk from wherever I started and could visually walk into the building, and I could do the doors, I could walk in the hallways, I could see people. I had to see it through their eyes to understand what great design was like. That's why I think design thinking in healthcare will be essential for the next phase of what we do and how we respond in the changes that we do in our next part of this. Dr. Gawande wrote an article here a couple of months ago about 5 essentials to manage the coronavirus in his hospital at Yale. And he said his biggest culture was The biggest challenge was culture, that they had a hard time getting people to respect each other enough to adhere to the policies. Well, you have to work on that kind of respectful culture long before you ever ask it to do something. That's why I go back. You have to work on trust before you need it. That's a massive challenge right now in all systems, in all industries, because now we're being asked for our people to sacrifice. We're being asked people to take risk. And if we haven't built a culture of trust before that, it's going to be hard to move to the next stage because don't know that they're going to trust what you're saying. That's also being played out on the national stage, guys. Who do you trust? This is another one. I applaud Dr. Tsai for having the courage to write the article about her own dilemma in the early phases of the pandemic. She was vulnerable. She had a history of asthma, and she took herself out of the emergency room because she was afraid of catching COVID. Then she became guilty. She felt guilty about her personal risk versus her obligation and duty as a physician. And she wrote about it in JAMA. I thought it was a great article, but I applaud people for being open enough to understand what I call the dilemmas that you struggle with when things become very real. We just have to have the courage to see things through her eyes and understand there are people who feel the same. And we all respond differently to challenges and risks because we don't know their whole story. But yet we need to try to understand why. I will tell you, COVID has created division. We have a lot of, as care has been divided and we had people move into virtual work and we had clinics shut down. Well, it became a pretty massive division between administration and clinicians, between leadership and operations, between primary care and specialists, between nursing and physicians, and all kinds of other divides. And all of them became, well, who's sacrificing most, who's compensated where? I mean, we even had CEOs there were some in other states, not here, who laid off a good portion of their staff one day and bonused the executive team the next. You can't be doing that. Those are things you have to understand. That trust has to be built earlier, and you have to have this connection between all elements of your staff so they trust and respect each other. When you talk about seeing things through others' eyes, when I was in the VA, my first week there before they knew who I was, I got a housekeeping outfit, and I worked as an inpatient housekeeper for a day for Ray. That's my boss, Ray, there. And Ray is an Army veteran in North Chicago. This is up near, right off the lakes. And he rides a bicycle to work and had for 9 years at that time, a bicycle, and he'd never missed a day of work. I said, Ray, why do you do that? And he goes, because these are my brothers. I'm here to serve them. Well, what I learned when I put that uniform on that morning, I went to openers and the other executive staff asked me what I was doing and what did I think I would accomplish with this. I said, I'm here to learn today. And then I learned something else while walking to the unit. Not one person said good morning or made eye contact with me. I was invisible for the first time ever in a hospital. And then I get on the unit, I'm dumping trash and I'm working, and I watch the nurse throw trash on the floor just to watch me go pick it up and put it in the trash can. Pretty interesting observation, but I had to see the world through Ray's eyes. And I will tell you, we changed some things. We changed a few of the procedures and policies. And then I had a little, they asked me to do a turnaround with one of them. And there was always a time limit to turn a room. They normally do it in about 28 minutes. And after we finished, I said, so how did we do? And he goes, well, I do it 28 on my own. I did it with you as 33. He goes, you tell me if it was good or not. So I learned right then, sometimes I'm not very helpful, but I learned a lot. And I wrote an article about some leadership lessons from this as well. But I will tell you, through all of these things that we're doing, nothing replaces the human touch and the connectivity and the personalness of healthcare. It's so important. And even through closed eyes, they can feel and see this. So one of the lessons another of those lessons I learned from Iraq is that connection is incredibly important, because some of my staff become a little callous, and I said, nope, you can't do it. These folks roll in here and they look up at you and they're injured, they're seriously injured. I said, you're the most important person they've ever met in their entire life. I have to assure you're worthy of that. Never, ever, ever become callous to this. Every patient we touch, it's a significant moment in their lives. Hard to do in healthcare with the volumes, but we have to understand the personalness of that and the importance and value of that. The last is you got to envision the future, and boy, is it painful sometimes. We get tossed and turned and twisted, and man, you know, is health our primary goal? I know some thinks that this may be really our iPhone moment in healthcare. Maybe the pandemic is going to expose it for what we really need to do. I hope we emerge from this thinking differently and we do something different. I'm going to ask you, are you going to do something different tomorrow morning based upon what you've learned? And who are we serving? And will we see value in our own system? How are we going to do that? So if you squint a little bit, you have to go, what's next? What can you see as next? What's next in your universe? And what's next for your organization? And what's next in our community, our state, and the nation? We need to really be open to that. And we need to try to see it differently based upon what we know and what we've understood. This is something this is a reality, guys. The pace of change will never be as slow as it is today. It's going to change much quicker as things move faster. So we need to redesign healthcare. Maybe so. But maybe we've learned some things through this pandemic. Maybe this particular moment has caused us to go, what the health? Maybe we can think about things differently. Maybe we can think about health. Maybe we can think about different collaborations. Maybe we can embrace technology. Maybe we can leverage data and information and knowledge differently. There's a few things. I like my friend Steve Myth at the Parkland Center for Clinical Innovation. He and Keith Kozel wrote a great book about the governance of connected communities and how we do that. I think we have to be able to connect county to state to federal. I wrote a plan in El Paso as a community forum to help the well-being of veterans between the El Paso government, the mayor, and the VA system, along with education and industry and jobs. Everybody sitting around a table focused on better opportunity for veterans in the El Paso community. Maybe we need to look at things differently like that. Maybe we need to have forums that are focused on health of a community that overlaps that economic as well as physical health opportunity. A great book, I'm going to pitch a book real quick on healthcare by Dr. Klasko and Taneja, who owns Livongo, and Dr. Klasko is the CEO of Jefferson Health in Philly. They really think healthcare policy now must evolve in ways traditionally it's been done, but politicians have never been willing to do it just because it's too risky on their part. Great list of 10 items. I won't go through these. They're available in your slides when you get those. It's a worthwhile read because it really focuses on creating an environment of health assurance, a process by which we can assure health for everyone that we serve. It's really, really powerful, and it does leverage a lot of technology, but don't do it all at once. There's not a big bang solution to that. Unfortunately, here is our reality, and this is the way our system is sort of structured and designed. But we have an opportunity to really change that. A few months ago, before the pandemic broke out, I had drafted a paper along with some partnered friends, physician friends, and created a vision of a system called MetaHealth. It was kind of challenging to the Medicare for All, because I said, I don't know that just giving access to our current healthcare system is appropriate for everyone. Maybe we need to start with holding people accountable by teaching them things first. So I created a federal program called MetaHealth. And it would be just visually here. You have Medicare for the over 65, you have Medicaid for those qualified adults, the free market in the middle, but everybody in the nation would have access to basic care, to health education, to prevention measures, prevention activities, public health information, and navigation of a healthcare system. And it would start frankly, before you're born. It would start with your mom. And then it would carry through to end of life, because we would be also making end of life decisions earlier in the stage. But it would be this entire system to assure health for everyone in the nation. But it got lost in the noise of the pandemic, so I will resurrect it again in time. I'll brush it off, and I'm going to keep proposing it. But because I think we have to provide the opportunity for every citizen in our nation to understand the path to health. Once they understand the path to health, then if they make bad choices, then we can hold them accountable in the free market. But I don't think we can afford to respond to everybody's bad choices for health. So, design of a great system means we have to come up with a new plan. I come back to this picture that I just love. Maybe we need to do things differently. So kind of here as we wrap up, I'm going to ask you just a few questions. Do you clearly understand your purpose in your organization? Do you know your purpose right now in the journey to health? Do you really know your why? And are your values and your purpose aligned with those of your organization? Do you fit? Or do you find each day kind of a struggle to become a part of that journey? And I've worked in places where they didn't align really well, because I really want to create health as an opportunity and help and serve those who serve others. Are you creating the right culture around you? And it goes back to the listening, empathetic. Are you seeing things through their eyes? Are you understanding? And are you data driven? Are we capturing knowledge and moving people and teaching people how to use that? The other challenge we have right now is do we really listen? Most of the time, and I find myself guilty of this too, we just wait to talk. Are you staying informed? And that's what I really applaud you attending this conference today, because I hope this helps you become a little bit more informed. Are you trusted? Are you creating relationships of people and organizations and others who trust you and trust your word? And I think you really have to look in the mirror and go, who you're serving. Are you serving yourself? Are you serving others? Are you serving an organization? And do you really care? Those are just things I ask you to ask yourself as we move forward. So, wow. If we know all of these things, then I think the next time we'll know what the health will happen the next time we have an attack. And by the way, COVID is not the last. We're going to have a lot of challenges in the future. There's going to be other health issues, healthcare issues, global impacts. We're going to have lots of crises that are coming. And we've seen ourselves vulnerable across many parameters, not only in our health status, but also our economic response and our systemness. We have so many things we can learn. But the most important thing is we have to understand what the health really did happen and what it exposed. And do we have the courage to step forward and change it? So I think we just need to look objectively at this new vision and new future. We really need to capture what I call data, turn that into the knowledge that I talked about, into the wisdom, and then help us mitigate the risk and manage the risk a little bit better as we take the next steps. So I just think we have to have the courage to kind of rebuild that camera we talked about earlier and create a better image of health for our nation, but health in relation to the entire world. So thank you for your time today. This is how you can reach me. You can find me at my Gmail or at UT Dallas, or if you just go to donald-taylor.com, that'll go right to my LinkedIn site. You connect with me there. So that's the end of my presentation, and I want to thank you all today for your time, your patience, and your attention. Thank you. Go forth and serve others.
Thank you, Don. That was a great presentation that gives you a lot to think about. And for those of us that are on the side of trying to gather the right data and create the right insights so that we can create that wisdom and knowledge